So in this video on ECG, we're just going to practice our approach to an ECG and go over some examples to kind of get an idea at least of how to assess an ECG on a very basic level. So first I want to talk about the approaches that we can take. So on this first slide here, this is one of the probably more common approaches. And I'll go through this one, and I'm going to go over one more example of an approach to take. And I think both are equally good and valid. And over time, you may come up with your own approaches, which is fine. But here are some ones that I've learned on, and that I think will serve you well. So one of the more common approaches is this sort of 8-step approach here, which actually, just to remind you, one of the approaches that should really be the first approach is to check your configuration. So this way you know what the scales are, how fast the ECG paper is going, and what the amplitudes are, and so on, so you don't misinterpret really tall R waves or low voltages or something. So after you checked your configuration, you take a look and see the rate, so you can measure the heart rates. Then that, of course, from that you can quickly assess if somebody's tachycardic and bradycardic, and next you can check the axis. And so the mean electrical axis by looking at the limb leads. Okay, so again, the limb leads are 1, 2, 3, AVL, AVR, and AVF. So you look at those leads to assess the axis that we've discussed in the previous videos. And if you know the axis, you actually can make some other assumptions too, and kind of work from there. So, for example, when you might see an axis deviation in multiple cases. So, for example, you might see a right axis deviation when there's right ventricular hypertrophy. If clinically that might mean that there was, let's say, chronic lung disease causing like chronic cor pulmonale, or an acute cor pulmonale, which would be like a pulmonary embolism, might cause right axis deviation. You could see axis deviation in bundle blocks. It could also be because the heart is actually physically moved or in a different position. You might see that in infants, for example, and so on. So there may be many reasons for an axis deviation. Same with left axis deviation. You could also have an enlarged or hypertrophied left ventricle. So it might be associated with that, and so on. The intervals. So the intervals, again, now we're looking at the waveforms and the length of time, the duration that they take. So for example, the P wave and the PR interval, so the combination of those two, the QRS complex, the ST segments, the QT intervals. So these are all of a certain duration, which is normal, which we've discussed. So for example, if we're measuring the PR interval, for example, that should be somewhere between 0.12 and 0.2 seconds. So you can quickly assess that. If it's too short, you may have a pre-excitation. If it's too long, you may have a block, for example. Then the QRS complex, the duration of the QRS should be less than 0.1 seconds. So you could assess its length to see if, or its duration, excuse me, to see if you may have an ectopic ventricular rhythm, so it's become prolonged. There's an increased duration. Bundle branch blocks can cause an increase in the QRS duration. So there might be multiple reasons, but if you see it's longer than normal, then at least it can lead you into that direction. And then, of course, again, the QT interval as well. And then finally, you can look at the rhythm, and with the rhythm, you can look basic look over to see the R to R intervals and see if they're regular from one R wave to the next. You can take a look at the P waves and see if the P waves are equally spaced apart, and that there's P before every QRS, and that should give you an idea of how regular this rhythm is, or if there's an underlying abnormal rhythm pattern to it, and then kind of go from there. So the first 4 I put in bold because those first 4 give you a lot of basic information that you can always kind of branch away from. So really just doing those four, if you don't remember anything else, if you do those four, you're probably in good hands and you'll be able to assess an ECG and be able to evaluate many different things. I added 5 through 8 as sort of reminders of important things not to miss, right? That really can be included in the first four as you're going through it. So for example, number 5 is conduction blocks. You might have assessed that already when you were measuring the intervals, for example. So if you had a prolonged PR interval, then you might already be assessing it for a conduction block. But I put blocks there as a reminder, so it could be an AV block, a branch block, or a hemi block, talking about like an anterior or posterior fascicular block. If the PR interval was too short, as I mentioned before, pre-excitation like Wolff-Parkinson-White can look for delta waves, for example. Again, that kind of could fall into the interval category. Hypertrophy. If you're looking at, say, the axis or even the rhythm, you might notice that there are very tall R waves in, say, in some of the leads, which might start to suggest, some sort of hypertrophy from increase in electrical activity and thus a larger amplitude. So then assessing, and using the criteria to assess for hypertrophy. And then lastly, I put coronary artery disease. So really what sort of encompasses in that would be looking for ST segment changes, so either an elevation or a depression, Q waves, and then any kind of T wave inversions and so on that might suggest coronary artery disease. And I guess with coronary artery disease, it's good to put it in context of the patient. So if the patient comes in with chest pain or has a history of coronary artery disease to begin with, or even a lot of risk factors. So that's really my sort of basic 8, and I really should add a 9th one, and that 9th one would really include seeking out any kind of help. So understand that ECGs can be difficult to interpret, especially in the beginning, and like I've said, cardiologists can also disagree among some of the findings. So when in doubt, you should always seek help. Now, I've also added something called an alternative approach. It's really just a different way of looking at it, and for some people, I think they may find this actually easier of an approach than the previous one. So it starts out with a looking at the rhythm. Same approach. Look at the rhythm. Look at the R to R. Look at the P to P intervals, and see if they're have a very normal flow to it, or if there's any differences between them. Make sure every P comes before the QRS and so on. And from there, in the rhythm, you can assess things like heart rate, for example. So that becomes part of that assessment. The P wave and the PR interval. So really what we're going to do in the next few steps is take each sort of section of the PQRST and break it down into components and just look at it piece by piece. So you can take the P wave and the PR interval. And the P wave, for example, should be most upright in lead 2. And you can assess for any kind of abnormality, so any kind of enlargement, so an increase in its duration, an increase in its amplitude. The PR interval, you can measure it just there, right, to make sure it's less than 0.2 and greater than 0.12 seconds. And that'll give you some information again about pre-excitation or blocks. The QRS complex. So the QRS complex, again, you can check its duration. You can look for R wave progressions to make sure that's normal in the chest leads, and it helps you kind of assess for even like Q wave abnormalities and really tall R waves that might suggest hypertrophy, for example. Looking at the QRS is also a good way to assess your axis and your limb leads. And then kind of moving forward, the ST segment. So in a coronary artery disease type case, you could look for elevations and depressions. And there'll be some other type of ST segment abnormalities that that we'll approach more in the cardiology lecture series. Then there's the T wave. So looking at repolarization. So you can see if they're inverted or peaked or even biphasic in some cases. And then go to the QT interval and U wave. So the QT interval is assessing all of depolarization and repolarization of the ventricles. and making sure that it's not longer than 0.44 seconds or 0.45 seconds. There's a little bit of difference between males and females. And that would be the QTC. Again, the little c just means it's been corrected for the heart rate, since the QT interval does change inversely with the heart rate. And a U wave is like another, it almost looks like a second T wave that appears, and it can suggest certain conditions like hypokalemia, or it may be actually a normal finding in a well-trained athlete, for example, or even in very slow heart rates. And then finally, once you've kind of assessed it all piece by piece and you've kind of putting everything into context, you want to compare it with any old ECGs that this patient may have. So that's actually important, and I like this part to this approach, which is, again, is something you would have to do in the first approach too, which just wasn't mentioned, was that you should always compare it to prior ECGs, because some findings may actually be totally benign, but if they are new for this particular patient and the old ECGs didn't show it, then it might actually be pathologic. And then finally, the clinical context becomes super important, because you can actually see ST elevations, for example, in a totally normal heart. And but if the person's in the emergency room and they're complaining of chest pain and elevated troponins, then ST elevations are not a normal finding. So clinical context becomes very important. So this is just another approach which I do like. So it's really kind of up to you how you want to approach it, but I would suggest, especially if you're a beginner, to try one of these first two. Okay, so let's start with some examples now. So in this case, we'll start with this very first case here, and I'm just trying to find a good color that I can use here. All right, let's try that one. So in reading this ECG, right, we can see first off, you can pick out your limb leads, which are right over here. I've circled them in orange for you, and then over here are going to be the chest leads. So those are our two different groups, and again, looking at the heart from sort of two different perspectives. You have the frontal plane and horizontal plane. So the limb leads are the frontal, and the chest leads are the horizontal leads. I've included for just the limb leads over here, okay, the frontal plane. So let's try taking the approach of the rate, axis, interval, and rhythm, just to kind of get the feel for how to assess this ECG. Down here, by the way, what you're seeing are some rhythm strips. So these are just prolonged, so it gives a longer time for these particular leads, and usually with the ECG machine you can kind of select which leads you want to prolong a little bit. 2 is a fairly common one to use, and some of the chest leads too, like V1 or even V5, can also be fairly commonly used. And so we give it more time so we can actually assess a rhythm a little bit better there. So if we take the approach of looking at the rate first, so again, the approach to that is going to be looking at the R to R, right? So if we take a look at let's use one of our rhythm strips down here, right? So we look at the R to R, and in fact, we look at every R there, okay? The R to R, we can count the boxes between them. The number of large boxes is about 3. So we see 3 large boxes between this R to R interval that I just highlighted. And if we actually look closely, it's a little bit more than 3 boxes. But if we do the countdown method, where we go each box, we go 300, 150, and then 100. It looks to be around 100 beats per minute, probably a little bit less since it's a little bit greater than 3 boxes. And then while I'm at it, I can actually check to see if it's about 3 boxes, or a little more than 3 boxes for every single R to R, which it appears to be, which is actually, it's a regular R to R interval. I can see there's a P wave before every single R, and these are the P waves right here. And they seem to be spaced evenly apart. So this rhythm is regular. So I just checked the rate and rhythm pretty quickly. Okay, so regular rates, or I would say borderline tachycardic, and it's a regular rhythm. So there's rate, rhythm, and then if we take a look at the axis. So the axis, again, I'm looking at leads 1 and 2 first. And the reason I look at leads 1 and 2 first is because if the QRS is primarily upward going in 1 and 2, then I have a normal axis. It's probably going to fall somewhere between 90 degrees and negative 30 degrees. So it would be normal. Looking at this at 1 and 2, I noticed that 2 over here looks like kind of an isoelectric complex, or like one of those biphasic waves that I mentioned, where the deflection upward and downward are about equal. And it should really be more upright in 2. So I'm going to look around at some of the other limb leads and see where else there is an upright lead or an upright QRS. And I actually see that in AVL over here, and I see in 1. So 1 and AVL actually have the most upright QRSs. So now I actually have to do an assessment to see if this falls within the normal range. So to do that, I look really next in the limb leads for the one that's most biphasic, which I think we found already, and that's in 2. So in 2 it's biphasic, knowing that 2 is, I'm going to show you over here, 2 is at 60 degrees, okay? And the negative deflection might be a little greater than the positive deflection. It's a little hard to say here, but let's say it's dead on 2, okay? Let's say it's biphasic at 2, or there's an isoelectric complex there. That means that the mean electrical axis moving through the ventricle is going perpendicular to lead 2. So if over here in 2, I'm going to draw it back to the heart here, all right, straight line back to the heart. That means 90 degrees to that is going this way over here as well, or this way to in this direction. You can go in either direction. It's 90 degrees. That's all I've figured out so far, is it's 90 degrees to 2. So that means it could be going towards AVL or away from AVL. If I look at AVL, AVL is upright, which means it's moving towards AVL. So it's 90 degrees to 2 and moving almost directly at AVL. So just based on kind of eyeing it up right here, it looks to be about negative 30 degree axis, which is very borderline left axis deviation. It might actually be a left axis deviation if in fact the downward deflection in 2 is greater than the upward deflection, meaning that the wave is primarily moving away from 2. Okay, so it's not exactly perpendicular. It's somewhat away from, which would put it something more negative, like negative 35 or something, let's say. But based on this estimate, it seems to be about negative 30, which is borderline left axis deviation. Okay, and again, we can look that up again, but there's different causes for left axis deviation, one of which might be, say, hypertrophy, for example. Maybe the person had chronic hypertension or what have you. So again, that's where clinical context really helps. So I see, okay, borderline left axis deviation. In the limb leads, 3 and AVF would be negative going because they're located over here. And if my main vector is right here, it's moving away from 3 and AVF, so therefore a negative deflection. All right, now if I take a look over at the chest leads, I can just kind of quickly assess that R wave progression to see if the R wave, so here's like a little R wave in V1, which is typical. All right, 2, it's still a little 3, 4, 5, and 6. It's biggest in 5, which is fairly typical. There is R wave progression. Okay, so the R wave progression is okay. All right, and then if you take a look at some of the intervals, if you want to practice for that, it's a little hard because I can't see all the boxes very clearly on this screen. But then if you had it on paper, you could even use a caliper, or I could use, just blow this up a little bit larger and I could count those boxes a little bit more closely. But just being able to eyeball it from where I am right now, the intervals look to be okay. The PR interval looks okay. The QRS is nice and narrow. And the QT, we're just under 100. So the QT, using that method that I talked about, if you want to assess the QT interval, let me see if I can find a good wave here. All right, so if we have the start of the QRS to the end of the T, and then the R to R interval. So it should be about half or a little bit less than half, about 40% of that R to R, and that looks to be approximate. So yeah, the QT interval looks okay. And then like I said, from that first approach, after that you can kind of look for any kind of hypertrophy. Do the R waves in any of the chest leads look like they're very, very tall? Which I don't see any of that. I don't see anything to suggest any kind of ST elevations or depressions. I don't see any pathological Q waves for coronary artery disease. The PR intervals were or excuse me, the intervals were normal, so I don't really see any issues with um, any kind of blocks or anything like that. The rhythm was all normal. So again, you can take it back and take a look at the first approach and kind of go stepwise, a little bit like how I did. I skipped around a little bit, so I apologize, but it hopefully gives you sort of the general approach. So overall, without having any kind of clinical context and not being able to compare it to older ECGs, this looks fairly normal with a borderline left axis deviation. All right, in this case, I actually gave you a little bit of a clinical vignette here to kind of help put this into a context now. So there's no prior ECG here, but hopefully we'll be able to see sort of a pattern here. And I have a 72-year-old man, right? And he's got a history of ischemic heart disease. So we know the heart is diseased. All right, he's unresponsive. So these are all clinical clues here, right? He has no pulse. He's not making any effort to breathe. And so really right here, this is the first thing you should recognize, for us who are, clinically oriented. It should be that this is an acute situation and one that has to be dealt with very quickly. So we're not going to be taking this ECG home with us to study for a while. There's something emergent about this and he's not responding. And oftentimes when a patient's not responding, it's because that there's something so, wrong with the heart's normal rhythm that the cardiac output has suffered to the point where the patient's not even conscious. So we take a look to the left over here, we can see that ECG, and you can see it looks fairly wild. It's difficult to really assess an axis or P waves and T waves and all that, and this really wouldn't be the appropriate time necessarily to do that. But in general sort of pattern recognition, given the history that we were dealing with, you'll notice this sort of pattern, and it's somewhat regular, and it looks like we're looking at those QRSs that are very, very wide. You can see that they're kind of broad, and it almost looks like it's sinusoidal, and the patient clearly looks tachycardic if you were to try to count the boxes in between and so on. So kind of with that in mind, given this picture, this is actually ventricular tachycardia, and the person's not responding. And we'll talk about what to do in the cardiology class actually. But in this case, this is somebody who we have to treat immediately. We have to recognize that this is VTach and not VFib. VFib would just kind of look like the baselines are all over the place with no clear patterns at all, not very regular. This does look regular. It is tachycardic. And sometimes it can be confused with PSVT, paroxysmal supraventricular tachycardia. And in a clinical context, it's actually easier to tell them apart because usually VTach occurs in older patients. They may not even be responding, in which case it's a diseased heart and there's something going on with the cardiac output and so on. Whereas in PSVT, this can happen in any age really, but you might even see it in younger patients, for example. And you could break a PSVT with a carotid massage in some cases, or adenosine, whereas that wouldn't help in this scenario. So in this case here, again, I give a clinical example or a vignette of a younger woman. So she's celebrating the end of her exams. She goes out drinking, and before she goes home, she wants to kind of sober up. So she starts drinking coffee to help her out. And she ends up going to the emergency room because her chest is going crazy. She's starting to feel this fluttering and these palpitations. And they do the ECG and they get this. And in a young female, I didn't give you any kind of past medical history or anything like that. We don't expect really any coronary artery disease or unhealthy heart or even heart failure per se. So when we see something like this is probably happening in a fairly healthy heart for the most part, right? And you'll notice that the QRSs all look very, very narrow. Like you can see them, they all look very narrow. And it's a very, very regular rhythm. If you were to take a look at each R-to-R interval here, and you look at all these waves, they're all occurring in a very regular pattern. The patient's also young and responding to you. And given this sort of history, these are all stimulants like caffeine, alcohol, and stress, for example. And that can actually induce a normal heart to go into this, which is a PSVT, a paroxysmal supraventricular tachycardia. So in this case, You could actually attempt a carotid massage, and that might actually break the rhythm. A Valsalva maneuver could do the same thing. So like hold your breath and kind of bear down. Um, if that doesn't work, you could also use adenosine, and we'll kind of get into that more in cardiology, but that could also break that cycle, because what's happening is this is usually, not always, but usually this is a reentrant circuit that's occurring in the AV node, which is why carotid massage works. When you massage the carotid, that can actually inhibit the AV node and break that electrical cycle that's going on. So again, this is a dysrhythmia or an arrhythmia that can often be pattern recognized, also based on clinical context. All right, so in this case, I didn't give you really anything. I didn't give you any clinical context. I didn't give you a vignette. And this particular source, they broke it up into little boxes, but these are all these leads were recorded. We'll assume are recorded at the same time. So you can practice those steps. You can do the rates, the rhythms, and so on. But just to kind of give you guys a clue, the next three, including this case, and then the next two cases, this was a patient that had gone to the emergency department complaining of chest pain. All right, so I'll give you that much of a clue, which is a pretty big clue. So again, practice your steps, because every single time you practice calculating the rates, rhythms, axis intervals, the better you'll get at it, the faster you'll start to see things. So in this case, I gave you a little bit of a clue saying, all right, there's chest pain, they're in an emergency room, so we know this is an acute situation. And if you remember from the steps, coronary artery disease was one of them, right? Where we look for ST changes, Q waves, or any T wave inversions. So I kind of wanted to draw your attention to that here. So if we take a look, so we look through the leads here, and we want to kind of see if we see any changes to, let's say, the ST segment, for example, any depressions or elevations. And if we look here at these are the limb leads, okay, and then we have our chest leads. So we look at the limb leads first, okay. I don't see any particular elevations just on glancing at it there, but then you see over here in V1 through V6, it looks like we may have a little bit something in V1 possibly, but definitely I'm seeing something in V2 and V3, and maybe even V4. It's a little difficult to discern here, but maybe there. It's possible it looks like V5 even. So it's a little bit difficult. Again, I would have to kind of blow that up and measure it a little bit more closely. But just to kind of give you guys a quick idea of how to assess those ST segment elevations is, again, if I have this is the P. Let's have a little Q, R, S, and then there's the T wave. Okay. And then this is my ST segment right here. Something I hadn't mentioned on a prior video is really this, what we call that point right there, which is called the J point. And our baseline for measuring whether or not the J point is elevated, meaning an ST segment elevation, or if the J point is lowered, meaning is below the baseline, is by looking over here. Let me use a different color for this. Is by looking over here, which is the PR segment. So it's that PR segment. So the PR segment is actually our baseline. So we look at this, that's our isoelectric line right there. So they should be, under normal circumstances, at the same level. Now, if I use the PR segment as my baseline, if the J point, by the way, is the point at which the QRS ends and becomes the ST segment. So it's the J point right here. Okay, so that's where the S comes back to the baseline, as you can see. So if I have an elevation, so let's draw that out. There's a P, and then let's say Q, R, and then it's S, and it kind of goes up. Excuse my drawing's not that great, but here's my J point right over here. Here's my baseline. If I draw a dotted line from here, you'll notice that the ST segment is elevated relative to the PR, that PR segment. Okay, so that's an ST elevation, and you can measure how high or how tall that elevation is by comparing it to the PR segment, the baseline. How many boxes higher than the PR segment is it? And again, the J point could be below that point, which would be a depression. And in cardiology course, I'll talk about ST segments, uh, elevations that could indicate something other than an infarct. But in this case, this is somebody with chest pain, troponins were level at a high level, and so we see ST segment elevations in V2, 3, and maybe 4 and 5 as well. So what I want you to kind of understand from this is that in those chest leads, what do those leads actually represent anatomically? And so just to remind you, V1 and V2 are usually referred to as the septal leads because they overlie the septum of the ventricles. V3, 4, and 5, V3 and V4 are usually considered anterior leads because they're on the sort of the anterior aspect of the left ventricle. And then V5 and V6 are on the left lateral aspect of the left ventricle. Usually we'll include one in AVL with V5 and V6. So if I see ST segment elevations in, say, V2, 3, and 4, then I would be calling this, sort of a septal anterior or just an anterior infarct or an anterior STEMI, an ST segment elevation MI. So that would be in V2, 3, and 4, for example. And so that's one way to be more descriptive about what you're seeing in the ECG. In addition, you can go a little bit further to see, what coronary vessel might be affected. So, for example, in V2, 3, and 4, if those were our ST segment elevations, it's in the anterior. It's an anterior STEMI, and then I could say, well, the part that distributes, or the coronary most likely to distribute to that, is probably the left anterior descending. Okay, so this might be some sort of an obstruction in the left anterior descending because that's the part that goes down the septum. Okay. So stop there. So in this case, same idea. So what you have is a patient coming in, emergency room. So it's a different patient with chest pain. So let's see if we can kind of just evaluate what's happening to this guy here. All right. So again, check all the leads systematically. Look, at your limb leads and your precordial or your chest leads, and see if you can find any abnormalities. Again, looking for ST segment elevations or depressions. And I apologize, in the previous example, I didn't look for any Q waves, which we should have done. So if you will have the time, go back and take a look and see if you can find Q waves. But be careful with the Q waves. Remember, we usually have normal physiologic Q waves, which you can usually find in those left lateral leads, particularly like in V5 or V6, for example. And they usually the amplitude shouldn't be more than one small box, and not usually wider than one small box either. But if it's pathologic, it's usually larger. Okay, it's more prolonged than one tiny box, and the amplitude of that Q wave is greater than or equal to about 25% of the R wave in that same lead. And with that said, you should see the Q waves in at least one other contiguous lead. In other words, leads that look at the heart from a familiar vantage point. So for example, if I see what looks to be a pathological Q wave in V5, all right, I have to look, there has to be another lead that shows that, another contiguous lead. So I would look at V6. If V6 also shows it, then we would consider that a pathological Q wave. All right, so let's come back to our case here. And we can see over here, I see an elevation, what looks like in 2, 3, and AVF. Let's see, AVL looks like almost close to a depression there, but we have definitely a depression here in V1. Looks like maybe even V2 and V3 here. I see some ST segment depressions. All right. Before I go any further, let's evaluate, before I go into the ST segment depressions and whatnot, let's see if we have any Q waves that we can find as well. So I can give you an example of that here, which naturally I don't see any right now. So no Q waves. And reminder, the Q waves are going to be representative of usually an old infarct, since Q waves typically persist for the life of the patient. So it gives you an idea if they've had infarcts in the past. So right here we have an acute infarct. Doesn't look like there's any signs of old infarct. I don't see any Q waves. And we see the elevations in 2, 3, and AVF. 2, 3, and AVF are our inferior leads, okay? And they look at the hearts from the diaphragmatic surface of the heart. And so that could be, the diaphragmatic surface, which would include some of the right ventricle as well as the left ventricle. The blood supply is typically the right coronary, so it could be a right coronary occlusion. And about 80 to 85% of patients, their right coronary gives rise to the posterior coronary artery, which actually descends and gives blood to the posterior aspect of the interventricular septum. So we usually refer to that as a right dominant heart. So often if you see ST elevations in 2, 3, and AVF, you should look over here at V1, because V1, the position of that lead is actually it's on the anterior side of the heart, but it would look it's sort of opposite the posterior side of the heart. And so it would usually show what we call a reciprocal change. So instead of an ST elevation, if there is an MI on the posterior aspect of the heart, it would show up on an anterior lead as an inversion. So I see an inversion there, and usually what's associated with that is also a taller R wave, and I can see kind of a tallish R wave for V1, and we see definite depression. So it's possible, it's not definitive, but it's possible that you have what looks to be like an inferior STEMI, possibly an inferior posterior STEMI, because it might be including the posterior as well. V2 and V3 are also somewhat depressed as well, which could just suggest that these leads are actually in a position that's somewhat reciprocal to 2, 3, and AVF as well. And again, with most of these cases, clinical workup is important. The physical, getting the labs, and then of course, if you see the ST segment elevations, getting them into to get either surgery or medication or whatever the next step should be. So in this case, again, assess all the leads systematically. Okay, and again, it's our patient, emergency room, chest pain, and what you're going to see over here. Okay, and many of the leads over here are ST segment elevations, also sometimes referred to as tombstoning. It kind of looks like the shape of a tombstone. So you can definitely see that. Looks to me that if we're going to look for Q waves next, oh, by the way, I can also see some here in 1 and AVL. Maybe some depressions in 2, 3, and F as well. So you can see some depression here in 2, 3, and AVF. Okay. So, as far as the Q waves are concerned, it looks like maybe V1 and V2 may have a Q wave here. It looks like a QS wave or a Q wave, and there's another Q wave right here. So it's in contiguous leads, it's pretty large. So that looks like a pathological Q wave, which suggests, in this patient at least, that this might be an old septal infarct since it's in V1 and V2. And now if we take a look at the ST, so that means that was an old infarct in the septum, but he does have a current ongoing infarct, because you can see in V2, 3, 4, 5, and 6, you have ST elevations as well as 1 in AVL. So if we're going to be specific about what's happening with this particular ST elevation MI or STEMI, since it's in 1, AVL, V5, V6, that's the left laterals, all showing ST elevations. The anterior are all showing elevations in V3 and V4, and the septal at V2. So this is pretty diffuse. And so you could call this an anterolateral STEMI, or an anterolateral infarct of the left ventricle there. The inferior showing those ST segment depressions are usually because they're reciprocal to some of those chest leads, and so therefore they show it going downward instead of upward. So there's no inferior ischemia or infarct in this particular example. But we have an anterolateral infarct for sure, and the coronary distribution could be both the LAD and the circumflex. The circumflex being the coronary that distributes to the left lateral ventricle. Being that it's both, it could be possible that simultaneously they're being occluded, which is fairly rare, but it could also mean that this is the left main coronary, which the left main is more proximal, and it's before the bifurcation, before it becomes the circumflex or the LAD. It could be an occlusion there, which would affect both those artery distributions. All right, in this case, I'm really just giving an example of the chest leads so that you guys can get kind of practice with some of the pattern recognition. So, and again, I just to reiterate, when you get these 12 leads and you don't know context or anything like that, you should always go step by step, looking at rate, rhythm, axis, intervals, and so on, and doing the appropriate approach. But this is just some practice to make sure I get you guys focusing on a couple things. So here, this is just looking at the chest leads. So you couldn't assess an axis in this case. But if you take a look at this, you'll notice if you're trying to kind of assess the chest leads for its R wave progression, you may notice that there's something going on over here, kind of the same thing over here, but then it seems to have almost its normal pattern, but the R wave progression is not very good actually. And the S waves are actually quite deep in V5 and V6, and that's not typical because usually what happens is we go through our R wave progression, the R wave gets larger as we go from V1 to V5 and V6, and the S wave is largest in V1 and gradually gets smaller as we get to V5, V6. But in this case, it's almost reversed. We have a very little R wave and we have a very large S waves in V5 and V6. So you might have noticed that it's not a normal chest lead pattern. The next thing is sort of a pattern recognition. If you notice this wave right here, you'll notice the QRS is actually prolonged. So we're looking at the intervals. The QRS complex is prolonged. It's greater than 0.1 seconds long. And so if we're measuring it's greater than 0.1 seconds, you'll also notice something along with it is that, maybe that's an arrow, not a very good one, but here's another arrow. You're looking at this area right here. There's also T-wave inversion. So we have these large S's in V5, V6, some T-wave inversion, and what kind of looks like an M or bunny ears in V1 and V2. So this characteristic sort of bunny ear, which is actually called an RSR prime, is indicative of a right bundle branch block. So this is an RSR prime in V1 and V2, V1 or V2 really, a widened QRS, T-wave inversions because you have some repolarization abnormality going on, and then deeper S waves in V5 and V6. So it meets all the criteria for a right bundle branch block. Okay, so in this case, this particular ECG's got a few things going on, and so we're back to sort of our standard 12. So for this, you should be going through your standard approach of calculating a rate. So let's just do that really quick to make sure we're all on the same page. So let's take from here to here. All right, those intervals there. So let's take our heart rate. All right, there's 1, 2, 3, 4, approximately 5 boxes. So this person's heart rates, you could take 300 divided by 5, which would be 60. So it's about 60 beats per minute or so. Or you could do the countdown method, whichever you're more comfortable with. The countdown would be 300, 150, 100, 75, and then 60. So about 60 beats per minute. So borderline bradycardic, right? But it's still fairly within the normal range. So if we look at the rhythm, there's no real rhythm strip here to use. So I gotta have to use the leads that I do have just to see if that rhythm kind of holds steady. Which, and actually, if you're looking at some of these other leads, yeah, those are all about the same. But it looks like I have a little deviation from that even within the same lead right here, where it's about 3.5 boxes. So what I would ideally like to have in this scenario is I'd like to have a rhythm strip, because I want to get a better idea what that pattern is, because I can't really tell you just by eyeballing it right here what exactly is going on. So this shows you that we need more information in particular for this. So that being said, if we move on, so the rhythm may or may not be abnormal. We need more information, and that's okay. So we take a look at intervals. So I want to draw your attention again. If we're looking at the PR interval, the P is usually most prominent in lead 2. So let's just look over here. All right, this is actually a very short PR interval. Okay, it's actually shorter than it should be. The QRSs actually look borderline. It looks like the QRSs might even be a little wide. So if you look around some of the QRSs here, these guys over here, it's a little bit borderline even here. It's a little bit borderline. It's not as narrow as we'd like to see it, actually. So with a short PR interval, the first thing that should pop into your head since you're doing intervals, if it's short, is pre-excitation. And there are various types, but one of the most common one is Wolff-Parkinson-White. So if we have a short PR interval, we should do, you may not always see it in all the leads, but you should look around at all the leads to see if you find this sort of gradual upsloping, this sort of concave segment to the QRS. So when you see an upright R, like over here, actually I just circled one right here, so these two both have it. You can kind of see it over here as well. In fact, many of the leads actually do show it. Over here you can actually see it. Yeah, so many of the leads actually show this, where you see initially is normally the R should kind of go up almost perpendicularly there, but what you're seeing instead is like this little gradual upright. So there's this little piece right here where it's just swinging upward. That's referred to as a delta wave. And deltas are what are found in Wolff-Parkinson-White. That has the bundle of Kent, so it's bypassing the AV node essentially and causing that characteristic look to it. So that's a delta wave. So this patient definitely is a Wolff-Parkinson-White. I need a rhythm strip to assess the rhythm a little bit better. And if you were to take a look at any kind of an axis, so let's just do axis for a little practice. I definitely don't see it primarily upright in 1 and 2 because again 2 is looking actually more negative if anything, so it's going away from 2 a little bit. It's upright in 1 and it's again upright in AVL and downward in 3 in AVF. So this looks to be possible left axis deviation. So we got a left axis deviation. We have a Wolff-Parkinson-White type picture. Okay. Okay, so in this case, again, let's practice that rate. So you can kind of go through that, count your boxes. We do have a rhythm strip down here, so they're using lead 2 as their rhythm strip. Oh, and by the way, some of you guys may be curious about what this is. All right, that's our standardization box. It's not actually an electrical activity there. That's just to tell you that the height of that box equals 1 millivolt, for example. So it lets you know what the standardization is so you can compare that to the amplitudes that you're seeing. So we're using 2 here, and we can kind of assess the rhythm there from that. But let's do the rate first. So let's find an R that falls on a line that's easy for us to analyze. So there. All right, so we count the number of boxes. 1, 2, 3, 4. 4 boxes. We're right within the normal heart rate range. I can see that it's typically about 4. It's a little bit closer over here, and then it goes back out to about 4 again. It's fairly regular. The P's and the QRS's are all where they should be. Okay, and again, this one occurrence right here, it's hard to say, but it is possible that the P wave looks okay. So I can't really give you an idea of what that is at this point. All right, but let's take a look at some other things. The rhythm looks fairly regular actually. The P's are preceded by, or excuse me, the P's are followed by a QRS. The axis down in 2, up in AVL and in 1. So, and it's moving away from that. So we can't really find any good biphasic or isoelectric complexes in 2. So I would say that this is probably like a left axis type deviation. So it looks like maybe some left axis deviation, fairly regular rhythm. I probably want to do a little bit more of a rhythm strip to kind of assess to see if there's a pattern with that. In other words, is this little blip that we're seeing here due to any kind of maybe regular type rhythm, sinus type rhythm, which you might see with a respiratory sinus arrhythmia, where it speeds up or slows down based on their breathing pattern. That might be helpful to know. And so again, if we have left axis deviation, there's a couple causes for that, one of which is left ventricular hypertrophy. So we should take a look to see if, how the chest leads look and our R-wave progression. And just kind of looking at here, the R-wave progression doesn't look great, to be honest. It's kind of small. There's not a really good R-wave in V5 and V6 as there should be. There's a primarily downward going S-wave there. Again, it's hard to to figure out what exactly is going on from that. But what we could say is that it looks to me as if we have these guys here, at least in, it looks like a QS wave in V2, V3. So let's see if there's anything else there. So yeah, I mean, this looks like there could be some old Q waves in V2 and V3, so maybe some sort of septal anterior infarct that had occurred, which might be why we're seeing some changes in the normal electrical progression through the ventricles there. All right, so again, so we looked at the rates, okay, the rhythm. I want to assess that a little bit more, and again, that happens. Rhythm, rate, rhythm, axis we checked was left axis deviation, and then the intervals. So we take a look at the intervals. Again, it's kind of hard to see with just this particular image, but it looks to me like the QRSs are narrow. The PR interval looks okay. So if I look at here, PR interval looks to be about right. Yeah, this looks all normal. The QT interval looks to be okay. Again, we're within the normal heart rate range, so we can do the kind of eyeballing assessment of the QT there. So intervals look to be all right. Okay, I don't see any ST segment changes, no blocks. All right, okay. So now in this case, again, I'm not giving you kind of any information to go off of here, but we're going to take our typical approach, which is to look at our rate, rhythm, axis, and interval. So let's get a quick rate over here. Let's judge these. 1, 2, 3, and 4. Okay, so you're looking at about 75 beats per minute. That seems to be consistent with what we're seeing. Again, no rhythm strip. Okay, but looking at the rhythms that we do have, seem to be very regular between the R to R and the P to Ps. Every P has a QRS that follows it. Okay, if we look at the axis, definitely not upright in 1, but we can see it is in 2, 3, and AVF. AVL is downward going. So this might actually be a right axis deviation. So let's see if we can find a biphasic wave. Nothing really clearly biphasic. I mean, we're pretty close in 1 right here, but it seems to be actually more of a downward deflection than anything else. So with that downward deflection, it means it might be slightly away from 1. Now to remind you here, I'll draw it over here. At 0 degrees is R1, that's at 0, and then AVF is at 90 degrees. All right, so I'm going to draw the lines right there. So if it were exactly perpendicular to 1, that means it could be going this way up here or downward this way here towards 90. AVF is upright, so it's heading towards AVF, which means it could be exactly at 90 degrees, but probably not, since there's actually more of a negative deflection, meaning it's probably slightly away from 1, so it's probably greater than 90 degrees, which we're looking at a right axis deviation. So regular rhythm, heart rate looks okay, a right axis deviation. So if we have a right axis deviation, one of the things we should be thinking about is a possible right ventricular hypertrophy, since that's one of the criteria for it. That means we have to look over here at V1. And so reminding you, the criteria for right ventricular hypertrophy is the ratio between the upward deflection R wave should be greater than the downward deflection, or the S wave. And it's of low amplitude, but it does look like the R wave is greater than the S. So that actually fits that criteria. We are actually seeing inverted T waves, okay, actually in 2, 3, and AVF. Okay, you can also see inverted T waves, so there's some repolarization abnormality occurring as well. And that may actually be indicative of some type of strain that's occurring on the heart, maybe because of the hypertrophy that's occurring. Again, a comparative ECG and clinical context would be really helpful here. You can see that in right ventricular hypertrophy in cases of pulmonary diseases, chronic ones. You might see sort of the strain pattern might be happening in like a PE, which would be happening acutely, although actually most commonly in a pulmonary embolism, tachycardia is typically the most common finding, which is not seen here. So there are multiple reasons which we'd have to look into that in the context of this. But what you see is right axis deviation, which led us to seeing this right ventricular hypertrophy type pattern. Okay. Otherwise, if we take a look at the rest of the precordial leads here. Everything looks, fairly okay, but you're still seeing those inverted T waves. Okay. Lastly, I borrowed this case. This case here kind of already tells you what's going on here. You get a chance to just look it over. But what it's really going to draw your eye to is if it's left ventricular hypertrophy. Again, practice all those steps. But you'll notice these seriously large amplitudes over here that are even coming off the paper. In V5, you can see it V5, V6, and even V4 and all that. But these are really large amplitudes. All right, you can see this in V5 over here. You'll also notice that it has an inverted T wave, which is common, or not, I shouldn't say common, but that can be found with left ventricular hypertrophy with strain, because this usually is clinically indicative of a heart that is, enlarged enough to cause these repolarization abnormalities, which may be, a poorer prognosis overall. So, some of the criteria for left ventricular hypertrophy would be, V5 or V6 with an R wave that's plus, V1 or V2 with their S waves. If the R waves in V5 or V6, okay, plus the S waves in V1 or V2 are greater than 35 millimeters, reminding you that one large box is 5 millimeters. So really, we're counting out really 7 boxes. If it's greater than 7 large boxes between the R's and the S's of V5 and V6 and V1 and V2, then that's one of the criteria. There are many criteria for left ventricular hypertrophy. The more they meet the criteria, the more criteria they meet, I should say, the higher the likelihood is of this. You might see left axis deviation, so you could look over here. It's upright in 1 and 2. And it looks to be primarily upright in 1 and 2, actually. So this looks to be a normal axis. And in fact, if we were to continue to kind of assess this, take a look at our rhythm strip down here. There's another finding in the rhythm strip. And if you're trying to calculate the heart rate, you'll notice that it's about 3.5 boxes or so between this one, and then it changes again, and then it changes, and then it really changes, right? You even have what looks like an ectopic beat over here. So this is not a normal rhythm. And in fact, if I look at the baseline to kind of compare the P waves, I can't really make out any clear P waves. In fact, this baseline is fibrillating. So this patient looks like they may have left ventricular hypertrophy with what we call strain, as well as being atrial fibrillation. And if we take a look up here, what I like is you can actually see it says repolarization abnormality, which is the inverted T wave. And then you have left ventricular with secondary repolarization abnormality, which is that line right there, and atrial fibrillation. So again, you could actually go through all your steps and have them diagnosed yourself, but you can see this kind of gives you a feel for how the ECG kind of records some of that information for you, including things like the QT intervals and so on. Okay. So this, this is kind of me going step by step through some examples, and obviously if we go back through there, we might find other things, and I welcome you guys to do that and see what you come up with. I also recommend going online and just finding ECGs on websites and practicing them. You can even just Google ECG and use the images and just kind of assess it for yourself before trying to find what the answer is, because the reality is you may not find that there is a diagnosis, because we have to put into context with other things often, but it can give us a good idea, and it gives you guys a lot of practice. So what I would suggest now is to find one of the approaches. You can take one of the 2 that I've mentioned and just use that as sort of your fixed approach for now until you can kind of get better at reading ECGs, and it'll make sure that you also don't miss anything. Okay. If you have any questions, of course, please contact me, and enjoy the process.